Okay, thank you, Cicely. And thank you, James, as usual, for that very insightful introduction. So today's topic, just lost my screen. 1 second, please. So today's topic is living with long-term mental health conditions and managing pain. In this month of October, we are celebrating both Black History Month and World Mental Health Day. In England and Wales, nearly 1 in 5 people come from a BAME background. Challenges such as racism, which can range from microaggressions to name-calling and even physical aggression, stigma, being seen as shameful or embarrassing to discuss, and inequalities such as poverty and unemployment can affect the mental health of people from BAME communities. In the UK, when it comes to mental health, as well as other things, Black people are overrepresented and are more likely to have a psychotic disorder and to be sectioned. In the year to March 2020, Black people were more than 4 times as likely as white people to be detained under the Mental Health Act. 321.7 detentions per 100,000 people compared with their white counterparts, or 73.4% 73.4 per 100,000 people. Black Caribbean people had the highest rate of detention out of all ethnic groups. Overall, it is estimated that detentions increased by 0.8% in the year to March 2020. Black people are also more likely not to access support. This can be because of language barriers, lack of cultural understanding by white professionals, financial barriers, feeling that they are not understood, or just not knowing what help is available and or where to get it. Black people also are more likely to live with pain instead of seeking help. They are also likely to encounter discrimination and institutional racism if they do seek help. So just a quick overview of long COVID right now. So long-term effects of coronavirus, or long COVID. For some people, coronavirus or COVID-19 can cause symptoms that last weeks or months after the infection has gone. This is sometimes called post-COVID-19 syndrome or long COVID. How long it takes to recover from COVID-19 is different for everybody. Many people feel better in a few days or weeks, and most will make a full recovery within 12 weeks. But for some people, symptoms can last longer. The chances of having long-term symptoms does not seem to be linked how ill you are or when you first get COVID-19. People who had mild symptoms at first can still have long-term problems. The symptoms of long COVID include many things. There are lots of symptoms you can have after COVID-19 infection. The common long COVID symptoms include extreme tiredness or fatigue, shortness of breath, chest pain or tightness, problems with memory and concentration, otherwise known as brain fog, difficulty sleeping or insomnia, heart palpitations, dizziness, pins and needles, joint pain, depression and anxiety, tinnitus, earaches, feeling sick, diarrhea, stomach ache, loss of appetite, a high temperature, cough, headaches, sore throat, changes to sense of smell or taste, or rashes. If you're feeling any of these symptoms, it's very important to get in contact with your GP or local health professional. So that just rounds up for me. Sorry if it was a bit long or long-winded today or a bit longer, but I wanted to put in as much information as possible. So thank you once again, and I hand it over back to Cicely. Thank you.
Thank you so much, Kombe, and we needed to hear that much because those are the things that we are having to deal with, and especially in the month that we are in. Now, I like the fact that the World Mental Health Day there says together we can make a difference. And that is the difference we are trying to make now by having these conversations, to lighten the burden for everybody, which we have all witnessed with the experience of the COVID. We know how much as a community we rallied behind each other to manage it well. And with that, of course, comes with, builds our resilience, which is what we have been very good at as a community. So for now, let's watch 2 video clips here to reinforce what Toby has said, and then we'll bring in, we'll bring in your comments on that. So allow me to share this. Okay, right. You may not see that for now, but I will come out and then come back in. So I believe you can now see it. And
for white people, I'm gonna need to question that a little bit. For myself, I have knowledge, passion, and interest in mental health care. Hi, welcome back to Undefined Truth. Today, I'm going to be talking about mental health in the Black community. So often I come across Black people, African Americans, Haitians, Jamaicans. If I'm leaving anybody else out, fill it down in the description box below. But this is all to say that people of color, primarily Black people, have this negative stigma of therapy where it's only for white people or other people outside of them. Let me just drop some facts for you guys to help build my case. Black people are 20% more likely to report severe psychological issues than white people. Black people sometimes experience more severe forms of mental health issues due to needs not being met and barriers to forms of mental health care. Things that influence the psychological issues or distress that Black or African Americans experience is due to exposure to violence and homelessness. Now, for all my freedom fighters out there and people who have all these theories, I want to say that there are so many underlying issues and history that I'm not bringing into this video. If you do have strong opinions, don't forget to leave them down in the description box below. So I just said that 20% of Black people are more likely to report psychological distress. However, only 25% of Black or African Americans actually seek therapy, compared to the 40% that white people seek mental health care. Those were the facts. Now let me tell you a little bit of my thoughts. In my opinion, Black people are experts on the problem. We can tell you who, what, when. We have a reason for this, we have a reason for that. And I'm not to say that these are not true. I do know that, as I stated, there are so many issues and so many underlying contexts that I'm not sharing that does go into these statistics. But I'm tired of talking about the problem. I'm here to talk about some solutions. No, I can't really speak on history too much, but I can speak on mental health care, and that's what I'm trying to do today. So you may be asking, why do Black people not go to counseling? You may know for yourself, but this is, as a whole, what research says. Black people don't talk about the topic. They have trouble recognizing the signs of when they do need to seek additional care, often not knowing where to find help. In most low economic neighborhoods, there's payday loans, there's Kentucky Fried Chicken, but yet there isn't a central location for where you can seek help. Another reason is overly relying on faith, community, and friends. But what happens when your friends or your community don't know how to deal with your abuse, with your trauma, with your loss? What do you do then? These are some of the reasons why the Black community doesn't know when therapeutic treatment may be necessary. So why do only a quarter of Black people actually seek therapy? Most don't trust white people to understand who they are, that they may have to change how they speak or how they dress just for them to get the help. There's also discrimination and prejudice that happens among the community. And often when Black people think of going to get mental health care, they often think of a white male or white female that they have to go talk to about their problems. As a result, the interaction for Black people in mental health care often are mandated, or that they have to do it because the courts have told them that if they don't go to therapy, that they'll lose their kids, or they'll go to jail for a longer sentence, or because they're caught up in drugs and they now have to go to rehab. And when something is forced upon you to do, it definitely doesn't breed warm feelings and vulnerability for you to share about what's going on with you. It comes from a place of being forced, and thus there's more resistance and more distrust. This is why I created Undefined Truth, because the truth about mental health care doesn't have to be the status quo. I really want to provide informative education to all communities, but primarily the Black community, because there are Black therapists, there are Black counselors out there who are willing to help. You only need to know where to find them. So I challenge you to use your interest, your knowledge, your passion to influence and better yourself, and hopefully it will better the Black community as a whole. For myself, I have knowledge, passion, and interest in mental health care, fitness, everything that it takes for you to live a healthy life that can influence myself and hopefully others around me. So I encourage you to join me on this journey here at Undefined.
Wow, that might be the story for America, but actually it's very new to us. We cannot relate with that. And so it speaks to us. It speaks to us, hence why we are having these conversations. Now, the other one I'm going to show you is on men and mental health and help seeking. Okay. In his own words, so this is a man who is so well known to us, Bruno. He's a champion for many. But if we can talk about mental health, why not us? Pain cuts across the class and across the status, the social status. So let me share that.
It says, in his own words, tough, honest, and straight from the heart. Yeah. And it certainly is. Because over the years, I've interviewed you many times, and you're very, very good at putting a brave face on it. Yeah. You really are. Right. You're really good at that.
A brave face on it now.
But in the book, when I read the book and read what you went through, it's remarkable you're still here.
Yeah, definitely. But at the end of the day, everyone's got to go through their bits and pieces. As long as I'm breathing, I can go forward and forget about what happened yesterday and think what happens today, to be honest.
It's a good attitude to have, and it's the attitude that's saved you.
Yeah, really. Definitely, yeah.
Because it was after you retired, that's when the problems really started. And the trouble being, that time, you're back in the 90s, and people, it was a different time. People weren't understanding about mental health, and also there was this thing about men, particularly men, particularly in the business that you were in, just didn't talk about it.
Well, women are very, very good at crying and unloading and chatting. Men don't like to chat. Men don't like to talk about if they're having a breakdown, if they're going through a bad time. They hide it, you know what I mean? So at the end of the day, I was the same. Yeah. And I wouldn't seek help and wanted to get help and just knotted up, and it's like a pressure cooker. Yeah. Once it boils over, it just goes, you know what I mean? But at the end of the day, we all go through a time in our life where we go through different dark days, lethargic days, haven't got no motivation or whatever. But it's nice to talk, and people are talking now all over the place and unloading and, you know, feeling much more better.
And it's, you know, partly due to people like you actually coming out and saying, I've had a problem. And the difficulty being, as I said, boxing is obviously very macho. And it's like, you're supposed to be, you're this tough guy, you know, you're supposed to be invincible.
Tough
Nothing's
guys
supposed to
go through problems.
They
tough
sure
guys do cry.
They sure do. And I mean, reading about it, the time that you had in hospital was really, really difficult.
Very, very difficult, very, very horrible, you know what I mean? I think I was being wound up sometimes when I went into hospital, because I would be in the toilet and you'd be nurses looking over the top, looking at you, going through, you know what I mean, winding you up, shouting at you, trying to, supposed to be there for you, but just every single day just trying to do things to
See, that's the
irritate
trouble.
you.
You've got that because of the man that you are in the job that you did, and in the fact that you were a champion.
Right, yeah.
Everybody knows you.
Yeah,
Everybody knows you. Everybody knows your story.
Right, yeah.
And you must get people, because there are some horrible people in the world, who will want to get some sort of reaction
And
from
try
you.
and wind you up. But I've never, it's horrible, but sometimes that's the way it was. I thought some of these places you went to go to, they're supposed to be on your side and helpfully. The aftercare team would come in and see them shouting at me, but they were embarrassed of certain different things that was going on. But no, I come through it, so I ain't got no complaints at all.
So let's hear your reactions to that. Have one or two reactions to the two video clips, and then we get Dr. Ibak in. Any reactions to what you have seen and heard? Okay. I know it was quite a lot, but you must have grasped one or two points there.
Hi, can you hear me? It's Angela.
Oh yes, Angela, we couldn't hear you. We can hear you now.
Yeah. I remember when Frank Bruno went through this crisis, and his was high profile because of who he is. You know, the hard man boxer and all of that. But actually, his point was men don't like to be seen to be crying. They don't talk about their problems, and they try to hide any problems they have. So there's a natural tendency in our, and I don't think it's just the Black culture, I think it's men generally, where from tiny age they're told big boys don't cry.
Yeah.
I can't even imagine how many times I've heard that. Stop crying, big boys don't cry. Well, big boys do cry, and there's every reason for them to cry in certain circumstances. We need to be better at understanding that your gender doesn't actually form a template for the way you should behave.
Yeah.
Thank you. Thank you, Angela, for that.
Okay. Yeah.
And I think we have talked about depression and suicide in the past, and that handling of the pain and how they manage it has been a key element to this. Yes, thank you for that. Any other comments? Yes, Rachel?
Oh, hello, everyone.
Hello.
Yeah, sorry. I think my own comment is looking at the two videos. It's actually trying to, what I actually gather is letting us to be who we are. I think most of the things is like, even though we live in a Western culture, and most things that are not really known who we are. For example, if I go to somewhere, I even had that problem a few days ago with my son saying that, oh, mom, you're shouting. And I said to him that, listen, I'm a Black woman. If you see me when I raise my voice, it's because I don't want to repeat myself constantly. And even though the country is trying, but there's a lot of cultural aspect from the young lady's video that people don't know about. People who have been there, that's what they said. You can know a problem, but you can know it to the depth when you've been there. And people who know your culture and your race and know how things are happening, they're the ones who can do it properly for you. Anybody else can try, but they will be just like being in a guest kind of way. But if they know the shoes that you're wearing, that they've been there before, they're able to direct you in the rightful way. Equally, it's like Frank Bruno, it's like we Black people, there's so many things that kind of bring us down religiously, morally, so many things says that, oh, I don't want to talk about my problem because I want to be strong. I've been growing up with this African, Caribbean culture that we have to be strong all the time. We have to, go by whatever is going on. We kind of digest it in our own way and not trying to talk about it. I think that's what I get from the two videos, is about knowing. And if we go our own people who actually know And for instance, like the program that you're running, I can come and say anything. That's why we want society to empower things like that, because I know I can talk to you in confidence. You can hear me better compared to somebody else who, the minute I open my mouth, they are reading it differently because they don't truly know my cultural background. So that's all what I wanted to add.
Thank you, Angela, for that input, which really relates to what Tombe presented in the beginning, and especially the lack of awareness of the services because of who we are gets in the way of how we manage our health. Okay, I see two hands up. We'll go for them and then we'll bring Dr. Deepak in. Now, number 85133, you are first, and then I'll bring Victor Eka in.
Oh, thank you very much. I think that is me. I don't know if you can see me. Oh,
we can't
yeah,
see you, but you
first
can
of all,
hear you.
good morning, everyone. Name is Bridget, and I just want to add on to what has been said. I think is Angela about knowing who we are and how to talk
Hi.
or to go for
We
help.
can see you now.
Can you hear me? Can you
Yeah,
hear
we
me?
can see you now. That's
Yes.
Okay. On the two videos, I think they are actually sending the same message. And I'll start with the Bruno, where he says he felt like he's being, did he say provoked when he is in the toilet and nurses are all over watching him. This is where we need to emphasize more on informed decisions, that Bruno did not have to feel like he's being invaded, his space is being invaded, or people are being intrusive. Because he was suicidal, we as nurses, what we do is to keep those people safe. But at the same time, we always need to have plan with them of the care they are going to expect from us to keep them safe. So if he felt that way, I don't know if that conversation took place to let him know how we are going to supervise his movements, because we talk with the people, we set ourselves how we are going to work until we feel they're not at risk of ending their lives. And then we slowly minimize those restrictions. I don't know who has felt like that in the past. I know sometimes we do take decisions based on the patient's presentation at the moment they are admitted, but again, that depends on who are the people providing the care. So, coming back to the point of sharing, talking, reaching out, seeking help, I think it's very important to have more champions, to have many people willing to come out without shame of what others will say, because this is what has left our people, or have made our Black community to be left suffering and without talking because of that fear. Many may not understand when I say people don't come out, because maybe somebody has gone out to seek help. I am a champion who is very passionate about mental health and reaching out to support our communities. I've just come back from Kenya, where I was for 8 months, and all I do is to raise mental health awareness. It's very interesting to know, as much as we know, in Africa, not many countries that have got that awareness, the understanding or accepting mental ill health is an illness like any other. You'd be surprised to know we have got people here, even with us, maybe on this platform as well, who actually don't believe mental illness is an illness that can be treated. And for that reason, we can comfortably talk on this platform, but out there will not talk to people who are out there to educate them on mental well-being. Why I'm saying that is because I worked with so many people suffering and struggling in silence, and nobody knows they are suffering. Just because I expose myself to those people, and tell them what I do. And that way they want to come closer to me to hear and to get the support. I did what I can, but I can only do too much when I'm alone. Interesting, I have received so many phone calls from this side, from people who are here, from people I know and some I don't know, who want me to have to make contact with their people who are suffering abroad. So many people. And you wonder, when we are here, those people don't talk about it. They don't even ask one another, how can I support my family member who is abroad? How can I do A, B, C, D? So coming to that point, I am saying we need not to shy off to talk about mental illness. If COVID started just the other day and everybody is talking about COVID and the prevention, the vaccinations, how to manage it, I don't understand why this illness that has been there hundreds of years is still not widely spoken about. It is sad because when somebody is suffering the COVID, we know the signs and the symptoms and we see how they are presenting. But mental illness, it will take long for somebody maybe suffering with depression to know their changes, unless you know them very well, or you are a family member, or you are professional. And those are the people who don't want to come out because they don't know what you will say, what you'll tell them. We need to help people to get out of this fear of talking about how they are feeling. And when I say that, I say, as somebody who has suffered with the depression for a long time, and when I suffered, it is the time I would have wanted medical attention, but I could not talk about it. It's a long time and I was young. I could not tell anybody about it because of fear of what they will say. But today, to remember that, I know that was not the end when I suffered. People are suffering the same today. So let us be champions who are willing to do something to bring change into our own people. When our people are suffering, we too are suffering. This is why we have seen so many people, especially young people, because they are still suffering and in silence, and they don't want to talk of what they are going through. They are getting, or they are seeking comfort from drugs and alcoholism. When they come to us, we treat the addictions. Yeah. What we don't know, there is mental health behind that, and that is what they are suppressing by the things they are using. Yeah. So this is something we need to do more, talking more, not on this platform, but everywhere else we go. Let us be champions, those who are willing to bring change into the mental health world. Thank you very much.
Yeah. Fantastic. Thank you so much, Bridget, because it's out of talking again, we will know the services that are out there and how to access them even. So for now, Victor, please do come in. And
right. Good morning, all. It's a comment was made. Big boys don't cry, which has triggered the something in me again. And I remember when my dad passed away. That'll be 39 years now, June 22nd of June. And, you know, this was a man who was in the forces. He was an army officer, then he joined the police, and, you know, he was fearless. He had been attacked so many times and he's always come out on top. And, you know, he became a role model. This man is invincible, he's untouchable, and then he died. Dealing with that emotion and being the, you know, the eldest son in the family, the responsibility for planning the funeral was mine. And I remember we had done everything, you know, being the man, you know, not showing emotion, not showing that it's affecting you. So I had to read a lesson during the funeral. Yeah. And towards the end of the reading, my voice cracked, obviously with emotion. Yeah. realizing that, you know, the end is really near for that relationship. And when I went back to sit down, my uncle dug his elbow into my ribs so hard. Don't do that. Don't you cry. You mustn't show this. This is not manly. You know? To the extent that for years after that, I became passive to funeral. I didn't know how to express sympathy because I had bottled up my own emotions inside and struggled with that for year after year after year. So I became impervious to death around me. It happens. Afterwards, my dad has died. I didn't know how to share emotion until Cecily kindly invited me to World Mental Health Day discussion as a guest speaker. And the topic was empty nest. And that was when I was able to talk about it. And I told her afterwards, I said, you've liberated me. This was a good 27, 28 years after my dad passed away. That was the first time I spoke about his passing. I just bottled that up because that was what was expected of me. And with other things that have happened, yes, Bridget is quite right. We must embrace the fact that there are mental health issues that may affect us, maybe in two varying degrees. Yes, we must also be aware that it's happening out there in the community. And it's up to us, you know, to be able to talk about it, to be able to advise people. This forum, yes, it attracts people, but it's only doing part of the job. A lot of the work needs to go out there, and each of us should be ambassadors to our communities to make sure that we intervene, we advise, we direct, we signpost to make sure that people's issues are dealt with. Okay, thank you.
Fantastic. Thank you so much, Victor, for sharing that and really emphasizing on the importance having conversations like this. Wow, I didn't realize that had that huge impact on you, but it is a story for many, I believe. So Angela, very quickly come in, and then Dr. Deepak will take over from here.
Yeah, very useful conversation. I think that, and I don't remember where I heard it, but it hit home, and it covers all sorts of crisis. If we go out into the community, our neighbours, our friends, our colleagues, etc., and we use one phrase at least once a day, are you okay? Because we do it in a work environment. We'll go up to a colleague and say, are you okay? Do you need help? Why not use that same phrase in a personal environment when we're meeting people we know, people that we don't work with, people that we meet at church, people that we meet on the street? It's a simple question to ask. And most people, whether they're suffering or not, will say, yes, I'm fine. And you just follow that up with really. And that's enough to open up that conversation. I mean, I don't know what Bridget would say to that, but it just occurred to me that it doesn't need to be difficult. It doesn't need to be complicated. It just needs to be done. That's all I had to add, really.
And yes, it's as simple as that. Thank you so much. Thank you so much.
Oh, I need to take my hand down. Sorry.
Well, yeah.
Okay.
Can I come in quickly? Can I say we still haven't got rid of the taboo and the shame that is associated with mental illness, probably. That's why we're not coming out to, you know, talk about it and seek advice. Because until, you know, recently, we knew if you were mentally ill, you roam about the streets naked and do all sorts of stuff.
Yeah.
You know? So we still got that mentality of taboo and shame and all that. That's why we're not coming out. Yeah, there's
a stigma around it.
Yeah,
and we will have this conversation more. So Angela, we'll come back to you. And the forum is about helping us understand the services that we can go to manage the pain and also to deal with most of the issues that we deal with on an everyday basis. And I noticed Recovery College is here and will be telling us more about the services that they are offering. But for now, I'll bring Dr. Deepak in with the service that we have not been able to access well, despite being hugely impacted on the COVID by the COVID. So over to you, Dr. Deepak.
Excellent. Well, thank you so much for having me on this forum, and it's been very fascinating and very useful for me and interesting to listen to the conversation that's been happening during this very important month of Black History, as well as Mental Health Day, really. And I just wanted to find out, Cecily, can you tell me how much time I have? Because I don't want to be taking too much time, because I said I would talk about pain and long COVID. Both are separate big topics in themselves. How much time do you think I have so that I can decide what to focus on for the needs of the listeners?
Yeah, 20 minutes, and I'm sure people will ask you questions.
Okay, then I'll try to separate it out as saying about 5 to 7 minutes on long COVID, and then about 5 to 7 minutes on pain management, and then we'll leave about 5 minutes for questions. Is that okay? If that's all right with everyone? Okay. I just will share a presentation that I made, just a few slides on long COVID, and let me know if you're able to see this slides there. Cecily, can you tell me if you can see this?
Yeah, it's coming through. Yeah, we are there now.
Yeah.
Yeah.
Okay, so I'm just going to, and are you recording this?
It's being recorded, yes.
Okay, that's good then. All right. So hopefully I won't try to take too much time, but one of the presenters in the very beginning talked to you a little bit about long COVID and gave an overview of the symptoms that people are seeing. So thank you so much. I've forgotten the name of who did that. So thank you so much for doing that, because it sets me up very nicely to tell you about a local service that's available for all of us here in the Berkshire area here. So my name is Deepak. I'm a consultant in pain management. However, I'm also the lead for the Berkshire Long COVID service. I work both in the community as well with the BHFT, which is the other organization. And in my team, where we do the long COVID and pain management, we've got access to physiotherapists. We recognize how much long COVID and pain can cause mental health issues or make ongoing mental health issues much worse. So we've got psychologists, we've got therapists and professionals who can help there. So that is definitely a support we can do there. A lot of the knowledge around pain and sometimes around long COVID itself is something that is not known to the public. And that is why I got involved in writing a book that came out earlier this year. What we understand with COVID is itself, it's not just a flu. As many of you who have gone and had, unfortunate, or if you know any family members who have had severe COVID, you realize that it is not really only a flu-like illness. It can be quite a significant problem that can affect lots of organ systems. A lot of ethnically diverse community members, especially like us and Asians, have been much more impacted with needing hospital and ICU admission. But we also realize that apart from those very unwell people who needed hospital, there is a bigger bunch of people who did not need hospital, who suffered with mild to moderate symptoms at home, but have never got fully better. And that is where the long COVID service is really helpful, because over the last 10 months, so we set up the service in December of last year, so December 2020. So we are almost been there for 10 months now, and we've had almost 900 referrals to the service up to now, and over 87% are from people who have never been hospitalized. So that's important to remember. So that means almost 700 people are people like you and me who have not needed to be admitted in hospital, but who have had symptoms that are going on long after the initial episode has gone away. Another factor is almost 70% are female, and almost 19%. So the census actually says that only 11% of UK population from 2011 were ethnic minorities. But in our long COVID service, we had almost 20%. So 1 out of every 5 people were from not the white community, they were from an ethnic minority. Blacks, Asians were the most common ones that we saw. And the common symptoms, as one of your previous presenters highlighted, fatigue is the most common. Tiredness and exhaustion has been the most common. Shortness of breath has been the next one. And then pain has been a common problem. There's been a lot of concentration problems and brain fog, and anxiety and depression also. New anxiety and depression and old anxiety depression getting worse is also been a problem because of having COVID. What's also been understanding is we looked at what the ethnic minority disparity is, how much inequality there is. And this graph is a little complicated, but what you can take away from those 2 pictures that you're looking on the slide there, that's the map of Berkshire that you see. And the top map shows the blue areas are the areas which are the high areas of economic deprivation, and minorities probably are higher in that area there. But when you see the lower graph here, the purple and the gray purple areas are the areas where we had the most referrals to the long COVID service. So you can see that the blue areas which are economically deprived and more ethnic minorities staying are not the areas where we've had the most referrals. So for some reason, either our communities are not reaching out for help, or are not aware of the service, or they are not able to see their GPs and then not get the referral to the service. And part of my desire is to address that finding and to say that we are here to help everyone, and that the more awareness we create for the service, the more chances that you can reach out to your GP and get a referral. We know that from data, almost 2 million people in the UK apparently might be having long COVID. And what we understand with long COVID is also that it has got lots of symptoms, and there is lots of organ systems that may be having symptoms from there. We are only now understanding about it. There are some similarities to other conditions, but we are thinking that right now it is a new long-term condition, and we do not know when it will be finished. There is no cure for it. There is no drug for it. This is something we are learning from the patients and understanding what is happening. But what we understand is that just because you had severe acute COVID, it doesn't mean you'll have long COVID. Even people who had mild infections can have ongoing symptoms there. So in fact, the US is so worried about it, they are calling it their next national health disaster. We are saying that 1 in 5 people or 1 in 10 people will have symptoms beyond 3 months. And you can see here that healthcare workers and teachers are almost 250,000 of the population. And what's most worrying is that a lot of people, almost 1/4 of the people, aren't able to go back to work after being in full employment. So this kind of mental health problems, fatigue and concentration has been reported after previous epidemics, like the SARS epidemic in Toronto and Hong Kong also had similar problems. And there is a concern that mental health is often the biggest. 40% of people, even after 4 years, will have mental health issues. So it is something we need to support our people, need to support the patients with. And there are lots of causes. The main thing is that the virus affects the immune system of the patient, and each one's immune system is different. So, as an ethnic minority, our immune systems are formed differently. It is a product of the environment. It is a product of what kind of food we eat, what kind of support we have, what kind of lifestyle we have. All of that will affect our immune system, what kind of trauma we've gone through, what kind of adversity and challenges we've gone through, how resilient we are, what is our community. All of that will impact on the immune system, and all of that can mean that when COVID affects it, we cannot predict how the immune system will react. In some people, the immune system may be very active for a very, very long time, and those kind of people are the ones we are seeing the long COVID symptoms. That is why we set up the service and said that anyone who's having symptoms 4 weeks after COVID infection, the acute infection can be called as long COVID. And we are saying that actually to be referred to the service, you do not need to have a positive antigen or a positive antibody test, because we recognize that when people were getting unwell last year in March, April, May, or June, they may not have had access to any testing, but they may still be struggling with symptoms in August, September, October of last year, even this year. So it is for all age groups. It is for all patients. And so if you do know your relatives or your colleagues or friends or family members in the community who haven't reached out for support, and you think that their problems are related, or they are telling you that it is related to after they have had a COVID infection, then do ask them to seek support. What we are saying is go to your GP first, and your GP should do an initial set of blood tests and X-ray if required, and then they can refer you to our service via an electronic form. Right now, the waiting times are a bit longer because we've had so many referrals come through, but we are still seeing patients. We are trying our best to get through them. And there are 89 such clinics. So if you've got community members and family members and friends in other parts of England, so it's not for Wales or Ireland or Scotland, but if you're in England and your family or friends are in England, then there must be a long COVID service nearby where you should be able to get the support and further management ideas. And what we are doing in our long COVID service is a combination. There may be some patients who are having heart issues or breathing difficulties, and they may benefit from some medication. There may be some interventions we can do for some patients with pain or fatigue. But what we are focusing and giving advice on is a lot around how to calm the immune system. Since I told you that the immune system is often the most hyperactive, so ways to calm it, advice around pacing your activity, fatigue management, diet, looking at the sleep, looking at other ways to relax the system is what we're looking at. Community engagement is very important. We've got some support from charities now to give some ways of exercise and physical activity and community engagement approaches with Community United and with other organizations in West Berkshire and with the councils. So we are doing our best to work with those organizations in Wokingham and Reading to see what all we can provide for patients in the community with their GP partners. This is what I'll leave you with. In case you want to know a little bit more about long COVID, please put it in the questions over there. And these are some websites, some kind of QR codes. So if you scan your phone at the screen right now, you should be able to get access. My recommendation would be the longcovid.physio on the top left of the screen that you see, and then the Royal Berkshire homepage, which will tell you how to go to your GP and what you need to do for getting support for your family members. So that is what I had to say about long COVID per se. Do you have any questions right now to take, or shall I talk a little bit about pain management and then we'll take common questions? Is that okay, Cecily? Shall I do that?
Yeah, that's fine. That's fine.
Yeah. So I will just go on and just share another slide around broad principles of pain management. As a lot of people have talked about, pain is again a very common symptom that is found in a lot of ethnic minority populations. There is a lot of overlap with pain and mental health issues as well, which can create a lot of problems for patients, and not knowing how to get the support and resources can often be a big problem there. So I'm just going to share another sort of presentation that I'll share. Hold on there. So let me know, Cecily, when you can see this.
Yeah.
Yes, we can see. Yeah.
Fine. So I'm just going to, I had thought I might have probably a little bit more time. So I'm just going to give the broad overview of what you hopefully will take away from pain management. As I said before, I am also I'm the lead and the clinical lead for pain management in the Royal Berkshire Hospital, and I also work in the community there. But what we understand now is that there are a lot of new advances about understanding pain that have come in the last 10, 15 years, which really GPs other healthcare practitioners, nurses, as well as my own colleagues and hospital specialists are not going to be aware. And that is what had prompted me to actually write this book and publish it there, because I think that's a very, and I've written it for patients like you, and to make sure you understand that it is a lot more complex. It is not as easy as we thought it will be, where everybody always thinks that pain is always coming from a structure. We realize that that's not true in every patient there. And a lot of problem is like the way medical healthcare has developed now, wherein we don't look at the whole person. Sometimes we forget to look at the whole person that is sitting in front of in the consultation. We look at one knee or one hip or one back or one neck, and then we say each specialist will just look after that small bit, and then you will go from one specialist to another specialist. So in all of this, it is difficult sometimes to know what is happening to the whole person, and sometimes that has a bigger impact as well. And a lot of this kind of super specialization that you see is because of this person in the 1700s. He was a Frenchman who suggested that all the pain will always come from one peripheral thing. There will be a wire that will go, a rope that will go from whichever part the body feels pain, and that will go to the back of the brain. And he suggested that if you can block it, cut it, or take it out, then there will be no pain. But what that did was that it separated the person from the body, and that the mind and the body got separated. And that is a big problem, because the science of the last 10, 15 years says that it is very difficult to separate the body and the mind. We are all one person, and our nervous system and our immune system, like you saw with long COVID, will always be interacting with each other, with interacting with the environment, and interacting with our family. So if you don't look at pain as what it means, when you look at why pain is there, then we will always have difficulty in solving it. So this model that has been taught in a lot of medical schools is actually quite wrong, and the science that we know. And actually what I tell my juniors and my other doctors and GPs when I do training is that a lot of what we learned in medical school is probably outdated and wrong. The difficulty is we do not know which 50% is wrong. And that is a tricky thing, because that's what you will find when you see your GP or your specialist there. Each one will say a different thing, and you realize that actually none of us are sure. So what I want to talk about pain management is for you to be aware. From my experience in the pain clinic, I often see people who have fallen off the waterfall, who have now jumped off and are very hurt and are in a difficult place. And sometimes I'm able to rescue them and make sense and make it easy. Other times I find it difficult. So half of my journey in the last 3-4 years is to actually see if I can go to the top of the waterfall and maybe sometimes try to find out metaphorically what to do to prevent people from getting thrown in the river in the first place, rather than falling off the waterfall. And so a lot of pain management right now is about thinking about the person as a whole, and thinking about why sometimes pain is happening in a person, and not just thinking about the structure alone. Because, and somebody made this point about, what are Black people taught as children to look at? You need to be strong, boys don't cry, and that's what happens. And so if you can think about a similarity, look at all these Disney and Pixar and Marvel movies like Toy Story 3, 4, Up, Pixar. And, there were some researchers who actually looked at these very famous, very interesting, very funny children's movies that we've all seen and we've told our children to see. And did you realize they looked at this, and the research they did was that they did a study looking to see in movies like this, and they looked at actually another 10 other movies like Frozen, Finding Dory, Sophia the First, and Peppa Pig. And they actually asked, how often is pain shown in these movies? How often are children, when they're growing up, shown the incidence of acute pain or chronic pain, and do the characters suffer pain? And can you just have a guess in your head what it might be? But you'll be shocked to actually say that almost 9 times an hour, pain was shown in these movies. Almost 80% of the time, the characters were shown to be seriously injured, but very, very less than 1% of the time were they shown medical or procedural problem. Chronic pain was hardly shown at all. And the worst thing was the characters were almost told that they should not be asking for help. They rarely asked for help, which means that actually, in a way, like somebody talked about, we are almost subconsciously and unconsciously programming our children that you are having a distorted perception of pain. And actually, where the pain was witnessed, there was no empathy. So even in movies like cartoon movies, there's no empathy for someone struggling with pain. And in all these movies, the boys were shown to be suffering from pain. The girls don't and were not shown as suffering at all. When in reality, it is women who suffer the most. And that's quite important because if you're talking about pain management, and we know that 60–70% of chronic pain is in women, then is some of it due to the way society talks about pain, media and Hollywood shock about pain. And actually, then if you're saying that you shouldn't seek help, then is that a reason that women often don't reach out for help until it is too late? That's something for you to think about, because this is not just a problem that is affecting ethnic minorities. It's the way society changes and distorts perception. Because the reality is that 1 in 5 of us will suffer from chronic pain, and 1 in 5 surgical procedures also will not work, leaving people with more pain. And the difficult problem is in medical schools, in nursing schools, and physio schools, only 10 to 20 hours out of 5 years is actually devoted to pain management and understanding pain. So there is a lot of wrong beliefs, which means that we need a new understanding and a new way of looking at pain. And the reality is that there are more people with pain than all of stroke and diabetes and heart disease and everything put together. And what we have to understand is that drugs or injections only work in 1/3 of the population. And my challenge to a lot of you who are listening to this, who are having pain or relatives with pain, is to think about it that if you see professionals looking for help with pain, you might see them in total for 2 to 3, 4, 5 hours in a whole year. Maybe each GP appointment is 10, 20 minutes. The question is, what will you do about managing your pain during the other periods of time? Because not everyone will know about the main pain signs. And that's where I'll just leave, because it is quite a big talk in that way. And maybe I'll come back another time to talk about it. But the broad strategies to manage it is again quite similar to what I practice in my philosophy, is that we need to talk a little bit more. Yes, there may be some medicines and injections that can help in some people, but now the evidence is actually there that when you understand what the pain is due to, when you can think about other ways to calm the nervous system down, then you can have a much better effect on your pain without necessarily having the side effects to it. Because the truth about it is that all pain is real. Everything is due to the way the nervous system processes the signals. And what we understand is that when you've had a trauma, for example, any kind of trauma in your past or in your present, or a road traffic accident or an injury or a fall, or even emotional trauma like distress or bereavement or death or anything like that, your nervous system is wanting to protect you. And that protection means it will make a prediction on how to protect you. And it will put those two mechanisms in place to protect you completely. So for example, this study there wherein a builder jumped on and you saw this big nail that goes through the boot, he was taken to the emergency department, and this case history happened about 10, 15 years ago. And they found out that actually they couldn't control him in the emergency department. They took him to the operating theaters, they sedated him, give a general anesthetic, and they pulled out the nail, took out the boot, thinking they'll have to clean the leg. And what they found was that the nail had got between the first toe and the big toe. It hadn't touched or caused any damage to his foot at all, but he was in a lot of pain. And that means that if the brain and the nervous system needs to protect you, it can create the experience of pain in order to protect you. Whether there is injury or not, it can do that. And that is what is important to take into account, is that pain is like an alarm system. It should tell us what's right, but it is not just an indicator of what is happening in the structure. It can go off as long as it senses a threat. And that threat can come from outside or inside. And that is what is important to remember, because if the threat is from various parts of the outside in terms of stress, in terms of poor food, in terms of infection, in terms of other injuries or trauma, then that can also cause a lot of distress and pain. And that is what I want to say, is that there is this difference between this word called nociception and what you're all experiencing as pain, because nociception is what occurs when you have an injury, a fracture or a fall or arthritis or a swollen knee. And for that, medications or injections can help. But when that signal travels to the brain and the brain makes sense of it and decides it must protect you, then for that kind of experience of pain, the medications and interventions are never going to be enough. You need to understand other strategies of managing the sleep, of the way to change the diet, the lifestyle, what kind of stress factors, what kind of activity you're doing, and what kind of relaxation strategies you do. That is the combination we look after. And in the pain management clinic at the Royal Berkshire or in the community, that's what we tend to offer. And you must remember that these both are not the same. They can be helped, but you must look at the whole part. And the optimistic and the hopeful thing is that it can always be changed. The nervous system and the signals can always be altered. And I'll leave you with this fact that, for lack of time, I won't cover it, but they're all strategies to do, which we cover in the pain service. And that is something we can talk about on another day. But just to understand that mental health and pain are very closely linked, because the nerve circuits in the brain and spinal cord are the same. When danger is sensed, they will do what it needs to protect you. And that can come out in different ways. And there are ways to manage it, not necessarily only with drugs, but there are other ways to do it in a holistic, integrated manner. Thank you.
Very useful.
Any questions?
Talk us through the day itself. How incredible was it for you?
Sorry.
It literally is.
Oh, sorry.
Sorry, I can see a few hands on here. Cecily, are you around, or shall I can see.
I'm around, but I'm sure there'll be a few questions on what you have beautifully presented. Okay. It would be nice to you put your hands up. Would be great. We already have two hands, Aris and Rachel. So yeah, so Dr. Deepak, take over with the questions.
Okay, I don't know. Okay, let's go with Alice then. Alice, as I see on the screen. Sorry. Yes.
Dr. Deepak, it's a very engaging presentation. I can tell you that I know. But what my concern is the left and the right are not talking to each other, and how do we do that? Because as the medical professionals have got a set of ways. The community has said we don't seem to be able to bridge this, and that has been the difficulty. Equally, with the resources that we have at the moment, there's always this dependency on the community, and that is become harder because we have been brought up, doctors know best.
Yeah.
We have been brought up to also to say what the doctor tells you, you do. We've never had a choice before. It's how do you empower the community when we've always been treated like doctors know best?
I think this is a period of lot of transition and change that is happening, Alice, because for example, the Royal Berkshire, our strategy itself from the chief executive officer downwards is to say, how can we work with the community to empower patients? And that is something that is explicitly coming from the NHS in the last 2-3 years. Obviously, that will be something that will take the next probably 4-5 years for all the GPs to start getting this into their head, for all the specialists to start understanding that each time they see you in the clinic or in a hospital setting, They not only have to give some advice, but they also will have to do a decision making that is shared with you, that they discuss with you what are the options, what are the choices, what is it that you should do. There will be some old style consultants or GPs who will be still like the way you describe, who will just say they know best and they will say something which you will find difficult to take on. But that is part of any change. You will find that the newer GPs and the newer doctors you meet will be more wanting to empower you and talk to you about how best to do that. I think this is something where both the community and the hospital has to come together and share ideas and find out which patients need that help from us, which patients will definitely need us to tell them, and which patients have full confidence that they can look after their health and they know where to go for further support. I think that is an ongoing dialogue, and I don't think we have the answers. I certainly, in pain management and in long COVID, I don't have the answers. I'm very much learning from patients and working with them and other support groups in the country to understand what my next step should be. Rachel? Sorry, Alice, yeah, go on.
But the thing is, though, I mean, because we are running as we, with this condition and things that we within ourselves, we don't know how to support. I mean, one of the things that my experience of long COVID has been, when you go as a patient to the GP, they turn around and are not keen to refer to your services, and and that is not the patient's fault. So, so how else can we, is there a self-referral system that we could help so that you could triage it to make it easier? Because somehow, because of the lack of knowledge between the medical staff, patients are not being referred to enough.
I think it's a delicate problem, Alice. And for example, right now, our waiting time for even those that are coming through the GPs is around 4 months to see them, because we don't, I mean, the funding that has come from the center is only been able to say that there, and we've got a huge number of referrals. So these are coming from the GP itself, we have 4 months. If we now said no investigations required, anybody from the public or anyone can self-refer, then we don't have any investigation setups at all. As you can understand now, even blood tubes and tubes for investigation are not available in many GP practices. So it's a tricky time, and I sense the frustration of the community in that part there. What we now have is, at least the GPs have been told from the top down, from the NHS, that they must look at patients with long COVID. They must do some training. They've all been given the training to see patients. And then if they can't refer or don't want to refer, they must give you the resources and support in there. We've got some extra funding to work with a couple of practices. So for example, the University Medical Practice, the Woodley Center Practice, so one in Reading, one in Newbury, one in Wokingham. We are working with 3 practices to actually help them, teach them to look after their long COVID patients in their own primary care network, so that they can support the patients quicker, see them quicker, and support them there. But as you rightly said, this is something we are all learning right now, and we are empowering each other. I'm empowering the GPs, and that's what we hope will make a difference. Right now, we haven't got that setup of self-referral there, because we don't have the ability to then investigate them or do the x-rays or blood tests. So that's why we are asking the GPs to do it, because at least they can do it a little quicker than us. Just understand that. Rachel, next.
Oh, hello. Thank you so much, Doctor, for this great presentation. I think you need to come again, and some of us want to hear more about it. Thank you. My question is basically with the COVID, we all know it's a pandemic, but the most sad and what is actually kind of stressing people more, and some people actually getting more sick, is like what Alice says. Sometimes you're calling your GP and you can't get through, and people actually who happens to get symptoms as well, they don't rely on anything when they say go and isolate yourself to stay indoors. And some people barely have to not to be able to stay home, but go outside and buy even ordinary paracetamol for themselves. So in the doctor's field or medical fields, we don't know, especially when the winter is start coming up, as we know that is part of respiratory issue, people are going to get more sick, and there's nothing in place what people could do when they fell ill, but just to stay home. And some people got their children and they don't know what they do. All that worries is bringing more mental and psychological health to people. So I don't know what's your take on that.
It's a very good point, Rachel. I think you make a very good point. I wish I could give you a ready-made answer there, but even I don't know what can be done. What do you feel would be an ideal way? Because I feel that some of this may have to be done at the primary care level by the GPs and the people out there. But what do you think I can go back and say? What do you, as a community, all of you have heard this, and Rachel makes a very important point as well. What might be one or two takeaway solutions which Cecily and me can actually take back to our organization? What kind of thing that we could do? Please tell me.
Well, for me, I think the most important thing is, first of all, knowing what medication. I think even when they're not answering our phone calls, but there has to be some certain thing in place. It's not when they said everybody is turning to their own doctors, we kind of start taking all these native herbs. We don't know what we are taking in terms of our lungs and boiling so many different things because you're not diagnosed. You're just been told to isolate yourself. So it has to be some form of medicine in place, even if they are not seeing patients, because if you're not on the list for medication list, they're not going to give you anything. So something has to be there, at least if you're getting terrible flu or what it is, for you to be able to take, but they can't just tell you go and stay home when there's nothing in place.
You're okay. I see what you mean there. Fine. I will take this back to there, because my understanding of acute infections right now, and I will say that I'm a more of a chronic pain physician there, but when you're saying the acute symptoms are going on, you want some kind of support and guidance on what should be the preferred options to take. Some of that advice is there, I think, on the Public Health England side, but I don't know if they are available locally and accessible to you. The understanding is that if this is a viral infection, then viral infections don't have any standard antibiotics or anything to be given straight off the bat. That is what my understanding is. But I will take this back to my emergency department colleagues and find out if this is something that they should tell the public, or maybe through Cecily, come back to your community, this forum again, to say this is what the Royal Berks and other primary care does. Would that be of help?
Yes, I should think so. I work in the hospital myself, but it gets frustrating when we have to face everything. Then our people home in the community are suffering. And that's why I always say thanks to this group. I live in Bristol, by the way. I'm pleased for this community setup, and I just hope they empower them more, because we learn so many things from them every day, you know. And thank you so much. And you need to come again. Thank you.
Thank you, Rachel. Thank you for that. Okay,
and also
Angela?
to emphasize, something else to mention there is that, you know, the NHS is quite open, and Dr. Deepak would say, and you all know that their constitution is for the communities, by the communities, and it's really about having that voice. So if we don't voice it out, they won't know. And like we ended last week about having a voice to the local authority, we need to really have it more to our health services. That's all.
Angela?
Yeah.
It's just something we said about, in fact, Alice said it. She said, we've been trained and taught that the doctor knows best. And in the same way that we've been taught that, so have the doctors. That's no disrespect to you, Deepak, but you hinted that there are some old-fashioned doctors who believe that, absolutely, they know best. But this is a new disease, and there are all sorts of symptoms listed that seem absolutely unconnected. So we're all living in an unknown world, if you like. I think for me, I am actually a patient of the University Medical Centre, and I have long COVID, not severely, but I do. And when I first rang up my GP, they were at a loss to tell me what to do. So I went to the government health website, and it was useful. If you have access to the government website, it's worth looking up COVID-19, because there are a list of symptoms. As you say, Deepak, it's very difficult to say what the treatment should be, but in general terms, they are saying you should take ibuprofen. You are allowed to take ibuprofen. That's not going to make you better overnight, but it will ease your symptoms. Beyond that, go to the GP and insist on being seen for any particular issue that you feel is pulling you down. But when you showed us the sorts of symptoms people have, like fatigue, I mean, I got COVID a week before my injection was due, my first injection, and then obviously had to wait a month. After having my first injection, and actually even after my second injection, I was still getting fatigue, and there's nothing you can do about that. There's no treatment you can take, no tablet you can take to take the fatigue away. And I think we just have to be a bit more open to the idea that this is not about going to the doctor and getting a pill, because it won't resolve it. There are so many different symptoms that come out with long COVID and COVID itself that may not hospitalize you, that we need to be a bit sensible about how we approach the treatment of it. And we need to recognize that sometimes our expectations of, you break a leg, they fix the leg, or you have high blood pressure, you take a tablet. COVID is not that. And we need to understand that and appreciate that there are some things that no one knows the answer to just yet. But I would recommend people going to the NHS website because it is useful.
Thank you. Thank you so much, Angela. I think that is useful. I don't think I can add anything more to such a comprehensive response out there. You are right. A lot of people do still get the benefits sometimes. I think it's natural for any human to feel a little bit worried when you have things that you can't explain and you've been working and been fit and healthy, and suddenly you have tiredness that is unexplained. And in this day and modern age, when you can swipe left and right and something arrives at your door in 6 hours due to Amazon Prime, you think that there should be a solution for everything. But you're right, as you rightly said, COVID is one of those things where realizing there isn't a ready-made quick fix for it. And some people need to hear that from a doctor. Some people can work it out and be confident and self-efficacious. Others need a little bit more hand-holding for a bit longer. And I think that's the nature of the, that our community itself. And that's where I think this kind of community support and what you're saying, that kind of confidence you're giving, hopefully will help others as well. Thank you for that. James?
Yes, I had COVID for some time. And I was conned by these people who are tracking and tracing COVID. But all what they were interested in is to keep him in the house, but not tell me what to do. As someone, Rachel here said, if you are just stuck in the house, you're not told what to do. So what next? If you go to a mechanic, if your car's a problem, do you go to instruct the mechanic what to do your car? If you go to a lawyer, do you go there to tell them how to advise you? I think there should be some minimum standards from the medical field to guide the community. Number one, we have a lot of disinformation that don't take the COVID vaccinations, don't do this, don't do that. So what's the minimum that a COVID patient or someone with long COVID should do to keep themselves healthy? Thank you.
that is quite relevant. I think it kind of reiterates same Rachel's point that the community probably needs a bit more advice on what to do during the acute COVID phase on terms of what they should be doing at home. And I think this is something I will take back to our emergency department and respiratory physicians. And it might be that we create some resource that is shared then within the community as a set of things that can be done or should be done. And that might help there. Okay, I'll definitely take that back there. Thank you so much for that feedback, James. If this is all right there, Cecily, I have got to jump off for another meeting. If there are any other questions, otherwise I have to go for a 1 o'clock meeting. Is it all right if I log off?
Yeah, it's fine. We finish at 1 o'clock, and so it's very timely. But as you can see, we need you back.
Absolutely. Give me another date sometime. I can go into a little bit more detail around what are the other resources for pain and long COVID, and maybe if I create something as well, then I'll make that available.
Yeah, that would be very, very kind of you. So we'll be following up with you.
Yeah.
Thank you so
much.
Time and the very comprehensive presentation. I wish we had more time.
Brilliant.
So for now, I know we have Anne from Recovery College with us. Thank you. We are providing a lot of courses to do with the resilience building. So Anne, it's your first time here. If you can just wave to us, and then we'll hand over to James as we finish. Hello, Anne. Yeah. So Anne, you'll be joining us quite often, regularly, I gather.
Yes, we can do this next time. Yeah, it'll either be me or one of my colleagues. Yeah, but we're very keen to hear from the community about what it is that we can work with you on. Yeah.
Fantastic. So that's Recovery College there for us to help us build our resilience even more. And so James, if you can come up. I have two Jameses here. So James, I think yours is a legacy hand, James Mover. So
yes. Okay. Oh, is it me or James the doctor?
The other James, yeah.
Okay.
James, you finish for us, and because we are
yeah, thank you, Cecily, and thank you, everybody. And I know the doctor just left. I think I'm not here really to summarize what he said, but I'm here to kind of take on what I actually picked from what he said. I think the fact that doctors increasingly are becoming aware that they need to share the clinic space or the treatment space, consultation space with us patients or client, I think it's really empowering for us to begin to hear that. And for us from the BAME community or the Black and the Caribbean descent, I think it's really important for us to be happy about this because our voices are seldom heard, and because of the languages, the nuances that are used within that clinical space, it's such a difficult thing for us. And that by helping us and helping them to understand us, because illness is really represented or exhibited from our own cultural dimension, as far as I'm concerned, from the literature I've read. So coming from what he said, I just really want to reflect on what Grace said earlier about mental illness. For us coming from Africa, when somebody's mentally unwell, he's or she's in the street, with really ragged attire, not dressed properly, they eat from garbage and all of those things. So until I came to this country, I never thought that mental illness is such a wide ranging problem for a lot of people, even people who are sober. I mean, look at Bruno. This was a boxer, he knocked people down, but mental health problem kind of knocked him down as well at some point where he was constantly monitored in a psychiatric setting because of suicide issues and all of those things. So it's really important for us to learn a lot from mental illness, because the taboo really, I think we as people have the taboo. The illness does not come with taboo. We label the illness with the taboo. We label it with whatever name we call it. Somebody's bonkers, is mad, is this, you're not fit to be here, you're dangerous, you're this. So we are the people actually naming it. We are the people labeling it. So it's really important for us to start removing those labels. So really, normalize it, to say, look, it's a problem. It can affect anybody. I mean, if we look at the statistics, which is saying 1 in 5 or 1 in 4, so it's here with us. And the sooner we engage with it, the better it will be for us and our community, and even for our own families. So when we come to long-term condition, I know the doctor has said a lot about long COVID, but there are so many other long-term conditions that we struggle with. And I'm really going to look at what we, the African and Caribbean descent, do suffer with, which is stroke and anything to do with high blood pressure. And there's so many other things, diabetes, there are countless, number of long-term conditions, but these are key. And they all come from stress because of what we go through all the time in our lives. So I'm not going to go into the detail because I think Tommy mentioned that in the beginning. So what I really want to look at, when we have long-term condition of any kind, the worry we have is, what I used to do, I'm not going to do them anymore. I'm limited now. This condition is going to be with me forever. I can't even take a walk. I can't even exercise the way I used to do. So yes, those are the fear we have. But let me leave you with some practical steps to take. What I'm looking at today really is about how do we pace our activities. And I'm going to inject the analogy of a ship. A ship with so many compartments, and the ship is sinking at sea. Maybe that's long-term condition. But the water is only filling one compartment. You have other compartments you can actually use. So it's really important to examine what I used to do. Maybe I'm not able to do now, but what abilities do I have now? Those are the abilities I need to really improve on, increase, and begin to engage in. That will really help. And that's what I call pacing activities. So you start by actually telling yourself, what is a sustainable baseline? What can I continue to do with this illness or up to the time I probably die? So that would be a sustainable baseline. If I'm walking like 10 miles, few months before the diagnosis, now I can walk maybe 5 miles. That is sustainable baseline for you. Do it. And the next thing now you have to do is to actually set your own baseline. What can I do every day? And if you set that baseline, it could be cooking, visiting friends, contacting friends. If you are one that was such a talkative, cheerful, engaging person, you used to call 5 or 50 friends or 15 friends per day, you're not able to call them because of your energy level, maybe drop it down to 5 or maybe 10. And that's increased that by 10% every week. That's how you begin to train your brain. I think we heard what the doctor said, that basically it's just a brain, the body telling us that, there's a crisis, I need to protect you. And they magnify the problem by not actually doing anything with it, but allowing you to feel a bit fearful, frightened, and worried. And that's the body. We call it somatic experiences. The body is telling you that, there's a disaster out, don't go out, it's very cold out. Even when you know you can wear your jacket, the brain is, it's really cold out there, don't even go there. I know very well, you can put your jacket on and go out and manage the cold. Just like when it's raining and you step out, it's raining and the brain says, it's raining, don't go out. If you have the right attire, you can actually go out for a walk. So that's how we retrain the brain. So after that, you build up your activities using SMART goals. What you can do is measurable. You time bound yourself. I'm going to go for a walk for maybe just 15 minutes and then come back. Tomorrow, maybe for 20 minutes and then come back. That's how you increase activities of any kind, even going shopping, cooking, talking, writing, even going to work. This is how you increase it. And believe me, you have to look at small bits often. You take it bit by bit, often, and don't relax. And eventually, you need to take regular break away from it. That's the time you relax. When do we actually come in our own present moment? When do we kind of keep our own company? If you're sitting alone, keep your own company, be in your own company, just enjoy who you are, even if you want to listen to music, just enjoy who you are. So it's really important to bear these steps, you know. And like I said, and like the doctor said, there are a lot of activities going out there, and there are a lot of support out there. Let's don't really stop engaging. Let's don't stop knocking the door. I mean, for some of us who are religious, we know that knock the door and the door will be open to you. The door is open to those who knock the door. So it's really important for us to engage with services, engage with ourselves, because sometimes we are really hard on ourselves. With any illness that comes to us, we begin to blame us. Maybe I didn't do this well. Maybe I've been eating too much. We need to look at all the other factors that can cause problems to us. So please, these are the steps that I would like you to take if you have any long-term condition. And please look after yourself for this week. And let's see what goals are you going to set for yourself for any kind, even if to contact a service, or maybe just invite sleep when you go to bed. Cut off all those external stimulants and just invite sleep. Tell sleep that I'm here now, come, I want to sleep. So that would be a fabulous thing for us to do. And let's don't forget the Black History Month. I want us to be proud of who we are. In any way or shape you want to show that, that's fine. For me, I'm going to show that in cooking, because my mom taught me to cook. So I'm going to be cooking most of the time this month, just to show how my heritage can shape my life. So I will leave you with those comments. Thank you so much, and we'll see you.
Fantastic. Thank you so much for finishing so well.
Yeah.
So let's end there and say, let's look forward to connecting on Thursday. We'll be exploring, how the issues we are all encountering, are affecting us all. Remember, it's also about mental health awareness. So energy has been one of the key subject matters in our TV screens. It is affecting us all. And we have Angela with us, who will be giving us 10 minutes of her time to see how we can manage that well without impacting on our well-being. But for now, do have a good week. And if you can join us before Thursday for sit and exercise and reflections on life's journey, we'll be sending the messages out.
Thank you. Wonderful.
Bye. Bye.
Bye-bye. Have a good one.
You look good. You look good. I like the attire. Wear it again, James.
Proud to be.
Yeah.
Thank you, Grace. Thank you.
I would have worn mine if I knew you were wearing one.
Oh, Grace, yeah. I was looking out for your granite soup.
Yeah, well, it's coming through the phone. Yeah, it's coming.
Bye-bye.
Bye.